So welcome to our third session, especially if you're just joining us now. And can I also remind you to use that hashtag we've got, RSMCOVIDconf, but only if you're going to say nice things about us. Now, our session is called Impact on the Brain, Nervous System and Mind, and if history is any guide, I suspect that in the long term, it will be the neurological and mental health issues that will provide the greatest ill health and the greatest challenges to society. But we're going to do those rapidly, but in order. And I'm going to just introduce the speakers as they come. So first of all, there'll be Professor Andrew Russman. And I need to also thank the Cleveland Clinic London, soon to be our close neighbors here, for specifically making his participation possible. You can read his bio in the program and presumably on the slide any second now. Obviously a top neurologist, clinical scientist and stroke specialist at the Cleveland. Not just that, remarkably civilized person. He did a history of art degree before being seduced by the bright lights of big cities of Boston and Cleveland. Indeed, much as I did as well. So, Andrew, over to you, and I'll remind you that, as I will all our speakers, the briefer you are, the more we will love you. Andrew.
Well, thank you, Simon, and thank you to the Royal Society of Medicine and the Cantor Foundation in order to support this important conference. You know, when we are looking, you know, both locally and regionally at our experience with the COVID-19 pandemic, one of the things we have to reflect upon is that we've learned so much internationally already from our colleagues. One of the things that we knew was coming to the US were potential delays or deferral in care that was occurring with patients with acute neurologic and, as we've already heard, cardiovascular conditions. So acute stroke presentations, we were first hearing about delays in presentation from my colleagues in Spain and Italy with reductions between 20 and 50%. In our own local area, I'm in Cleveland, Ohio, in the US, we've seen about a 30% reduction in acute stroke imaging and clinical presentations during the early portions of the pandemic. Now that for us, when we really started to see a state of emergency declared was actually in early March. And over the preceding 2 months, we saw this significant reduction. Now we've certainly seen the volume of patients presenting significantly pick back up again. When we were under a stay-at-home order during this early part of the pandemic, there were much more patients just staying home. Now we see more patients presenting, but significant delays in presentations and patients refusing to present. I have had countless circumstances now with patients who have called my office talking about new stroke symptoms that they're having and refusing to go to the emergency department, refusing to present to the hospital. And I think you know, the harm that's being done through this is really something that the individual patient can't estimate, but we see from our own experiences. This is not something that we should take lightly, and obviously we'll talk a little bit more about what these deferral and cares mean for the individual patient. When a patient does present, we've seen lots of systemic changes that we have to make in order to be able to manage care for our population. Not only have we instituted new plans of how to evaluate patients in the emergency department, we've instituted even more telemedicine. So in our traditional teaching hospital environments, we utilize mostly resident physicians and fellow physicians, as well as staff physicians to physically be present in the emergency department for acute stroke evaluations. These are rapid assessments in which we don't spend as much time determining, let's say, what the patient's potential symptomatic exposures were beforehand. So we have to have appropriate PPE available in that emergency department environment in order to protect the caregiver team and to take the best care of the patient as efficiently as possible. In order to have that PPE available, we have to appropriately stock and station that material, and that's obviously critically important. We have to maintain our teams. In order to be able to limit the exposure of the teams, we've introduced more telemedicine into that environment. So now resident physicians work with a staff physician or fellow through a telemedicine unit, where we've done this significantly throughout our health system over the last 10 years. We've really found how important this is during the pandemic, because it limits the number of caregivers that have to be present physically at the bedside, but maintains the standard of care that's so important. And this type of technological shift that still maintains the standard of care is obviously critically important. And this is in reference more to the evaluation team. Obviously, when we're talking about stroke care and stroke emergencies, assessing patients for neurologic deterioration, even after they've presented, is also critically important. And that means that we have to limit the number of people that are doing those examinations in order to potentially protect the caregiver team, but have those that are doing the examinations wear the appropriate PPE. And we've been fortunate that we have adequate stocks of PPE in order to be able to provide those services. But it's just so important that we continue to be vigilant about the need to not only steward our appropriate resources by reducing the number of the number of caregivers that are evaluating patients, thereby reducing the amount of PPE, but have that appropriate PPE available at all times. We've seen other systematic changes besides telemedicine. We've seen, again, relaxing, as I've heard earlier in our discussions today, of regulations related to use of technology to make these assessments. That's been critically important in delivering as much care as possible to our stroke community and being able to care for patients after they leave the hospital. But for those who don't have technological or access to the technology necessary to do the telehealth, I mean, although most patients do have smartphones and have the capability to interact, we have patients who aren't able or don't have the means to have that technology. And we have to be able to offer that care to them in the office environment, but do so safely. And again, we screen every patient coming into the hospital, every visitor, every caregiver on a daily basis for what types of symptoms they may have. And every patient going into the hospital is tested for COVID-19. And this has created an environment where we've had a significant control, we feel like, over spread of the pandemic within the hospital environment. Now, we've seen among patients who've presented a variety of different etiologic causes for stroke, many of which were the etiologic causes that we're all familiar with. We have seen some increase in the viral associated thrombophilias, whether that's, as I think I heard Dr. Goldhaber mention earlier in his cardiovascular talk, whether that's in situ thrombosis or cardioembolism or embolic etiologies. Those, we've seen both of those presentations, and we have to be aware, are there potential identified markers that would signal different treatments? Is there, as Dr. Goldhaber mentioned earlier, are there potential indicators that someone might benefit from more anticoagulation or other anticoagulant approaches in this population? Obviously, that's more complicated in the stroke population. In the ischemic stroke population, anticoagulating a patient may put them at risk for intracerebral hemorrhage as a complication or a conversion of their existing infarct, or it may put them at risk for other complications that we would like to avoid. At the same time, we don't want them to have more thrombotic complications. It's balancing this risk becomes so delicate. We've seen a lot of patients present with acute carotid or other vascular occlusions. And I think that much like other infectious etiologies that cause systemic inflammation, the COVID-19 pandemic we've seen cause quite a lot of plaque disruption, endothelial dysfunction that leads to acute vessel occlusion or artery-to-artery embolism that we might see in that population. And as we think about these different causes, we have to be cognizant that we're always innovating, always looking at our patient population to see what we're experiencing differently. And we've done this by meeting regularly, both as an institution. We have a daily meeting at at 4 p.m. every day, where we hear about some of the latest advances and what's going on with the number of cases within our own health system. But we also hear and have shared experiences of our colleagues internationally. If we have operations in other parts of the United States, in Abu Dhabi, in London, where we're able to share these experiences and talk about how we can work together and continue to monitor and change our systems of care in order to meet the challenges of the pandemic. Thank you,
Okay.
Simon.
Well, thank you very much. That was excellent. And thank you also for being a member of the Society of the Abolition of PowerPoint, which I have helped founded for many years. Now then, stay around, obviously, because we're going to get you back later on. But now it's a great pleasure to have the next person up, Dr. Hadi Manji, who's the president of the Royal Society of Medicine's section of neurology and a consultant at Queen Square. And Hadi and I go back a very long way to our origins at Trinity Hall, Cambridge, where we were in adjacent years, back before the First World War, I think. I haven't actually seen you, Hadi, for years and years. And I'd like to say that neither of us have changed a bit, but wouldn't quite be true. Hadi,
Simon.
Thank you so much.
Simon.
Over to you.
Thank you, Simon. Thank you, the RSM and the Cantor Foundation for this invitation. So look, we had an inkling that COVID-19 could cause neurological complications from the experience of the SARS and MERS epidemics of 2003 and 2012. But the numbers were really small, 8,000 SARS patients, 2,000 MERS patients. And one study on SARS brains showed that the virus was present in the brain on autopsy series. So then the first papers came out from Wuhan in China, and that suggested in one cohort, 36% of their patients had neurological symptoms. And these were headache, dizziness, facial pain, muscle pain, but it wasn't clear whether this was due to the virus itself affecting the nervous system, or were these the complications of hypoxia, systemic illness and viremia, or metabolic complications. Next slide, please, Victor. And so we published this study in Brain about 4 weeks ago, and this was a retrospective observational study, which is what most of the data is at the moment. It's all observational over a 5-week period that we encountered at Queen Square and UCLH. Now, these were highly selected group of patients, but I think they do give us a flavor of the spectrum of neurological complications that can be encountered in this group of patients. Now, Andrew has talked about strokes. Next slide, please. So I won't go into that very much, but the first point is to say that there was no real correlation between the severity of the COVID-19 respiratory illness and the neurological presentations. And in fact, some patients presented with a neurological problem first and then subsequently developed COVID-19 lung problems. That's the first point. So then coming to the groups of patients, the first is a group of patients labeled as encephalopathy. And by this included patients with delirium. So that's altered awareness, cognitive dysfunction, and occasional seizures. One patient presented with a psychosis with auditory and visual hallucinations, and also the Capgras phenomenon or the imposter syndrome. Now, these patients tended to be older, more than over the age of 50. Imaging studies were normal. CSF examination looking for other causes of infection and the COVID-19 virus were negative. But on the whole, these patients did well in terms of outcome after they left hospital. The second group are the ones we label as encephalitis, so evidence of brain inflammation on clinical grounds and on MRI. And again, CSF examinations failed to show evidence of the virus in the CSF. Now, this may be because our tests are not sensitive enough, or that the virus is very cell-bound and there's no free virus in the CSF. But again, these patients were treated with steroids with variable outcomes. The third and fourth groups are patients that could be labeled as post-infectious syndromes, immune-mediated. And the first group affected the central nervous system is this syndrome of acute demyelinating encephalomyelitis, which is a well-recognized syndrome post-viral, usually in children and after, for example, influenza infections. And in our group, they presented with headache, altered consciousness, and focal neurological signs. And the treatment outcome was variable. One patient died. She had necrotizing encephalitis or encephalopathy. The others had variable responses to the standard treatments of steroids, intravenous immunoglobulin, or plasma exchange. And one patient needed a decompression craniectomy because of raised intracranial pressure. And in her, we managed to get brain tissue, which again showed no evidence of the virus, but did confirm inflammation and demyelination as expected. And then the second group of post-infectious syndrome were those patients with Guillain-Barré syndrome. And as you know, Guillain-Barré syndrome is well recognized as a post-infectious syndrome after Campylobacter or Mycoplasma. And these patients, again, in the situation of COVID-19, presented with the same sort of pattern we normally see. And the response to treatment was, again, with IVIG, was variable. Some people did well, other people took longer to recover. So these were the sort of patients which we have encountered. And I think it's useful to have a platform of these syndromes which can be utilized by colleagues all around the world. Now, the other group now, which is coming to bear, and this was mentioned by Lord Kekar, are the patients who've been discharged from hospital or never went into hospital in the first place and may have had pneumonia, or chest infection, which is not serious enough to admit to hospital. And they're now presenting to us with symptoms of brain fog, headaches, myalgia, and pins and needles, the sort of symptoms we've encountered before in the post-viral syndromes. And this is the group that's going to need to be assessed, and we need to have long-term follow-up of these patients. So Simon, in summary, I think what's come through this last 6 months is that neurological conditions can occur in COVID-19. And we need to be aware of these because early diagnosis will have a better outcome. And in patients who presented with these syndromes, COVID-19 is now on the differential diagnosis. And I'll finish there, Simon.
Okay, thank you very much, Hadi. Sounds like I've spent 2 very happy years at Queen Square. Sounds like you might need people like me back one day. Okay, now then, Emily. I hope Emily is here. I hope we can see her. The last speaker is Dr. Emily Holmes, Professor Emily Holmes, who's a remarkable person because she's actually taken time out from her holiday in northern Sweden, where she's been battling wild boars on sledges somewhere beyond the Arctic Circle. So hopefully you're with us. She has honorary chairs at both Oxford and Cambridge and a full chair at the Karolinska in Stockholm, and is one of the best experimental and cognitive neuropsychologists of our age. I think I can say that without fear of contradiction. So Emily, hopefully over to you.
Yes. Thank you, Sir Simon. And thank you very much to the Royal Society of Medicine, and in particular to Dr. Cantor for supporting this, and to all of you watching. And I've hugely enjoyed the talk so far. And what I'm going to do in this talk is pull back a little bit and talk more broadly about mental health, which is something I think we're taking increasingly seriously as a really important aspect of the COVID-19 pandemic, and something we're going to need to do something about. So I had the pleasure of working with Simon and others, an international group, this spring, of people from a whole variety of backgrounds, of those of us working in mental health, so psychology, psychiatry, neurology. And we were able to survey and interview about 3,000 people in the UK just as lockdown was happening. And what we're very interested in is both what people's problems and mental ill health was reported as being, but also what opportunities were there for preserving well-being. And this survey was conducted with the support of the mental health research charity MQ and the Academy of Medical Sciences. And what we came up with was a call for action. And I hope by the end of this talk, you'll agree with me that one of the things we're going to need to do next across all of these areas is to start to consider mental health aspects more deeply. Next slide, please. So what we're seeing is that that COVID-19 exacerbates mental health inequalities. So we're not all in the same boat. Some of us are in super yachts and some of us are in small boats with one oar. And what a pandemic can do is have profound responses both at a physical level but at a mental level. And these boats, as it were, being pushed apart in their inequalities. So vulnerable groups, we're seeing a rise in mental health illness across countries, from China initially, Italy, Sweden, the UK, particularly in vulnerable groups who already have an existing mental health problem, but also tipping people towards increased levels of anxiety, common mental health problems such as anxiety and depression, as well as, of course, those with more severe mental illnesses such as schizophrenia, bipolar disorder. But then we've got to think about the different groups in society which this may be particularly affecting by the very measures that we're using to deal with the pandemic. So isolating children, keeping them away from school, for example, affects those children, particularly those children at risk. Isolating elderly people has consequences. Some speakers have mentioned today about the indirect effects of some of the measures that we're taking. And we also see unprecedented burden in some minority groups or ethnic minority groups. And alongside that, we're seeing an interest in thinking about mental health of very specific groups related to COVID-19. So as you've just talked about, Hadi, people who've been in intensive care, for example, whether it's delusions or whether it's other mental health and stress symptoms that may persist long after the illness itself has subsided. And one group raised by Dr. Kanter in his thanks were frontline healthcare staff. And these are staff who are working under unprecedented conditions in many countries and seeing increasing levels, for example, of what we call psychological trauma. Now, that puts a strain in two ways, both not only on the individual's mental health, for example, post-traumatic stress, but also in their functioning and delivering the kind of care that both they want to do and society stands to benefit from the years to come. So this is a very important group to understand better and to do something about. So when I'm talking about mental health interventions, what I want to sort of add is a note of optimism, because much of mental health is highly treatable. The big problem or scandal of our age is that most people around the globe don't receive adequate care, either in any country. And so I think the pandemic gives us an opportunity to really put a lens on this, think about the impact we can do in terms of treatments at individual level, just as Andrew talked about how we need to change our care to remote delivery, digital care, for example, when delivering a therapy is entirely possible. But we also need to step back and think about how we preserve and look after mental health at a more social level, public health interventions. And this is the first pandemic we've had 24/7 media reporting. We're seeing studies from America showing that overconsumption of stress-producing media, again, leads to mental ill health. So another aspect of public health is health messaging. And understanding the psychology behind this is one way to fast-track behavior change, which is exactly what we need to do to break the cycle of transmission. How to get people acting on social distancing when that's needed, how to engage sensibly in health behaviors. It's not as simple as simply telling the public what to do. We can use science to adapt that messaging and create more effective ways of so doing. Prevention is key, as what we're hearing across these talks is that the pandemic is here to stay for some while. Next slide, please. So what I'm really hoping in the bus that Dr. Kanter talked about is that we start putting mental health, not in the driving seat by any means, but in a seat very close to the driver. There's no health without mental health. All conditions are aided up by looking at both body and mind. There's much to do in terms of protecting vulnerable groups. And a challenge ahead is to think about intervention innovation, not just watching, as we're seeing many studies demonstrate the increases internationally, but actually looking at creative, innovative ways of intervening and doing something that can work on a more global scale. As I wanted to underscore that psychology is key to changing behavior and therefore key to public health. And perhaps the way forward is to do exactly in the spirit of this conference, is to really work in a much more interdisciplinary way, where we don't sit in separate professions and disciplines, but combine together to joint goals about how we wish to do something, whether that's breaking the chain of transmission or looking at sustaining the mental health of the population over what might be a prolonged period. So imagine the difference that it might make actually starting to properly address mental health now, changing pandemic-related health behaviours, not only for us sitting around listening to this conference, but for future generations and internationally. Thank you very much.
Emily, stay a second. Okay, thank you very much, Emily. And just stay with us just for a little bit before you return to the snow and ice outside. We haven't got that much time, but two things. But first of all, you mentioned behavioral science and behavioral change. Tomorrow at 12:30, we'll be running a session specifically on that with probably two of the world's leading authorities on that at 12:30, so join us for that. But again, pandemics are known to be about the history of inequalities. That's gone right back through history, but also have been about the history also of innovation and change. So in the few little minutes we've got left, can I ask each of you in turn just to suggest, what do you think in your particular area might be the newest innovation or the newest change that might emerge for the optimistic side of this otherwise rather pessimistic scenario? Let's just start with you, Andrew.
Well, I think it's, there's not one thing that we have learned probably, but if I had to talk about one experience, I think many of us have experienced changes in healthcare throughout our careers, but to be confronted with something that threatens the care of such a large group of patients and has really affected our ability to be able to deliver care by not having the patients necessarily present for care. I think one of the things that I've personally, biggest takeaway for me is to create systems of care, to be able to adapt with the pandemic to what the patient's needs are in this environment, and to do so rapidly and to some scalable extent. So it's not just to be able to provide some telehealth service to a patient who isn't able to or doesn't want to present for evaluation, but to do so for such a large population of people, to adapt our physical structure, to be able to create systems in order to optimize care for each individual patient and to have that care continue throughout the continuum. I think the biggest lesson for me has been how to create adaptability, how to create scalability to the systematic changes that are necessary in order to care for patients during the pandemic.
Okay. Hattie, in your paper in the Green Journal, you mentioned the possibility of new treatments, I think.
Yeah, I mean, I think the point is that so far, what we haven't got is enough data in terms of mechanisms of what's causing these neurological complications, from delirium to ADEM. And I think what's going to be needed is international cooperation to get more data. And when you get the data, then you can make the hypothesis, and then you can plan optimal treatments. And I think that is going to be the key. So far, if you look at all the publications in neurology, they're all observational.
Yeah.
Further insight into the mechanisms to provide us better treatment options.
You're absolutely right. They taught us well all those years ago, didn't they, Hattie? Yeah. Okay, Emily, is it new ways of delivering the same treatments or new treatments that we might find?
Both, Simon. So I think on an optimistic note, you can take a lot of what we call evidence-based treatments, particularly for anxiety and depression, now deliver those digitally on the internet, which is a great way of reaching people. But I think new's needed. I mean, what we really ought to be doing is combining forces and creating much more rational, effective, briefer treatments that can be scaled up globally and quickly if we're looking at the scale of numbers. And I think we ought to be taking much bigger risks. We haven't, really moving leaps forward And the way to do that is through mental health science, and looking at a much more mechanistic way. You can look at mechanisms, psychology and behavior, just as you can in molecules or circuits. And those are the things that those are the levers we can push to create much feistier, more pointed treatments that we can deliver to more. And I also think that we ought to seize the digital age, perhaps have treatments that look like a talking therapy but digital, but also capitalize on the fact that people are using their smartphones to do gaming in radical ways all over the world. And we're going to talk to my global health colleagues. People are using their smartphones everywhere. So let's go for it. Let's be radical. Let's invest in mental health science.
And brilliant. And indeed, to anyone who doesn't know, your own work on digital methods and the prevention and treatment of PTSD is a spectacular example of using brain and psychological science for new treatments. So thanks to our speakers, thanks to the outstanding generosity of the Cantor Charitable Foundation for making this possible,